Hello, everyone. I'm Claire Webster. I'm the founder of McGill University's Dementia Education Program, and I'm very happy to be here in person for the Caring Conversations hybrid webinar. This is the first time that we're actually doing a hybrid event where we have people in person as well as online. So just to give you a little bit of background, the McGill University Dementia Education Program offers a comprehensive range of free educational resources. One of our most important resources is the Dementia Companion Guide, which can be downloaded for free, and it's available in 14 different languages. We also just launched an online education program of 10 modules, both in English and French, and we have a lot of other resources that are accessible to you. So Caring Conversations is an initiative of this program. And we are very grateful to be able to do what we do thanks to private donations from many donors. So today we have the most registered people that we've ever had before. 240 people have registered. And today's session is being recorded so that people who are not able to attend could come on afterwards. So let's meet our moderators. We have Lucy Barilak. She received her Master of Social Work from the McGill University School of Social Work. She has developed evidence-based training for seniors and caregivers, and she has lectured in the field of social gerontology and presented in major conferences. Her research studies have been published in numerous journals. Ms. Barilak received the Queen's Jubilee Award for her role in developing a national coalition to support caregivers across Canada. And I have Joanne Besner. She is an educator, professional coach, and caregiver. She received her Bachelor of Social Work and Master of Business Administration from McGill University. Her 35-year career in public community healthcare in Quebec spans many roles, including frontline case manager, clinical supervisor, manager, researcher, and trainer. So today's topic is managing hallucinations, delusions, and paranoia that's associated with dementia. We ask that you please keep your microphones turned off. We will unmute people as needed once we open the discussion. And I'm handing it over to Lucy to begin.
All right, welcome everybody. So let's look at the title today. We are going to be talking about hallucination, delusion, paranoia associated with dementia. So we're going to look at the agenda, what we're going to be presenting today. So what we're going to be doing today is I'm going to slightly talk about dementia for those of you who've just started your caregiving journey. We'll be speaking about hallucinations, delusions, paranoia. We're going to give you tips on how to handle this behavior, and we're going to look at prevention. And one of the most important things is we're going to also look at hope, because there's always hope. So let's look at what is dementia. All right, so dementia is an overall term for a set of symptoms that is caused by disorders affecting the brain. Symptoms may include memory loss and difficulties with thinking, problem solving, or language severe enough to reduce a person's ability to perform everyday activities. Dementia reduces the brain's ability to interpret and understand information. A person with dementia may also experience changes in abilities, mood, or behavior. These dementia symptoms are irreversible, which means that any loss of their inabilities cannot come back. So you see that there's this umbrella, and the reason it's there is because dementia is the umbrella term to describe many kinds of dementias, including Alzheimer's, Lewy body, vascular, frontotemporal, and Parkinson's disease. Now, we receive many emails from caregivers, and sorry about that. So let's look at what are hallucinations, delusions, and paranoias. People with dementia may experience hallucination, delusion, and paranoia. So it's really understanding the differences between these can be helpful to you as well as the person you are caring for. Understanding why this happens and how to manage it is actually crucial. So let's look at what is a hallucination. It's a false sensory perception of objects or events. Individuals with dementia might see, hear, smell, taste, or feel something that's not there in reality. Example could include insects crawling on them or hearing people talk and thus responding to these voices. Tasting things that aren't there, for example, like a metallic taste in their mouth. They could even smell things that aren't there. For example, they smell smoke or they smell perfume. Now, the next one is a delusion. A delusion is really a false idea or belief. Now, they really do believe that it is real. This can sometimes come from misinterpreting situation. Examples could include a person with dementia thinking of family members stealing from them or that the police are following them. Now, what is paranoia? It's a kind of suspicious delusion, all right? For example, they're accusing a caregiver, a care partner of being unfaithful. I also want to say that delusions are more common in dementia with Lewy bodies and can affect people with Alzheimer's disease and vascular dementia, particularly in the later stages. They are less common in people with frontal temporal dementia. We get many emails from caregivers, and I would like to share 3 of them with you, since they illustrate some of the difficulties that caregivers may be facing when the person they're caring for displays signs of hallucination, delusions, and paranoia. So here's the first one. My parents are both in their 80s, and dad is caring for mom, who has Alzheimer's, for the past few years. On my last visit, mom was very agitated and was not herself. She was pacing up and down the living room and refused to sit down on the sofa. I asked her what was the problem, and she said that the cat was sitting on the couch. My parents do not have a cat, and there certainly was no cat sitting on the couch. I tried to tell her that there was no cat, but that made her even more agitated and upset. It took a long time for her to finally go and lie down in her bedroom. What is happening to her, and what should we do? In the last few weeks, my mother, who lives with me and my husband, has started behaving very strangely. Mom has dementia, but recently she has been talking to someone who's not there. It appears she's actually having a conversation with this invisible person. She looked very happy, smiling, and having a good time. I asked her who she's talking to. She said, Joe down the street. I was so shocked because mom was forgetful, but never did this before. I told her that no one was in the house, but she got very upset with me and told me that I don't know anything. Did I say something wrong? What should I do? And the last one, my husband was diagnosed with dementia 4 years ago. I'm his main caregiver and truly love this man very much. It is becoming very difficult for me in the past few months. Michael has started to accuse me of taking money from his wallet. He has not carried any money in his wallet for many years. I tried to explain to him that I never took any money and asked him to stop accusing me. He turns his head away and stops talking to me. This has been going on almost daily, and I'm very frustrated and don't know what to do. It is becoming very difficult, and I feel so lost and not knowing where this is coming from. Yesterday, he accused me of having an affair with the neighbor next door. Thank you for listening. Maybe you can relate to their questions as well. Think about your own experience and how you handle it. Now, I want to talk a little bit about research. Research tells us that non-medical interventions are preferred. While non-drug interventions are often effective, medications can be helpful and needed for some. Therefore, I'm going to start with non-medical interventions. So we're going to look at that. All right. So the first thing that I want to tell you, if you see something that's going on, their behavior, you have to assess the situation. So what I mean by that, take a big breath, step back, and kind of look and see what is actually going on. It's important to remember that hallucination and delusions may or may not be upsetting the person living with dementia. Not all hallucinations are frightening, and not all delusions are paranoid in nature. Sometimes they may be the result of a person trying to make sense of things. For example, the person may not remember putting their purse away and concludes that it must have been stolen. When helping someone who is experiencing hallucination or delusions, the best way to start is by arranging a consultation with the person's doctor. The physician can look for physical causes such as kidney or bladder infections, dehydration, pain, or alcohol drug abuse, all of which can cause hallucination or delusion. It is also possible that medications being prescribed for pain are the cause. If the physician prescribes a medication, watch for and report any side effects you notice, including oversedation, increased confusion, tremors, or tics. Even over-the-counter meds can cause someone to hallucinate, become paranoid, or be delusional. It also may be helpful to have the person's eyesight or hearing checked. This should be checked regularly. Make sure the person wears their hearing aids and glasses at all times. It's important to observe how the person responds to the hallucination or delusion. If they don't cause problems for the person, excuse me, it's typically best to ignore them. It's also important to avoid arguing with the person about what he or she sees, hears, or believes. It's not a natural, it is a natural reaction to try to correct the person, but unless the behavior becomes dangerous, you might not need to intervene. Leave them alone if they are not upset. Very much what the letter with the mother who was talking to someone, she was very happy until the daughter intervened. So let's look at tips and strategies, all right? So when the person appears to be upset about the hallucination, it's so very important to reassure them with kind words and gentle touch. For example, you might want to say, don't worry, I'm here, I'll protect you. I'll take care of you. I know you're worried. Would you like me to hold your hand and walk with you for a while? Gentle patting turn the person's attentions towards you and reduces the symptoms. Also, look for reasons or feelings behind the hallucination or delusion and try to find out what it means to the individual. For example, you might want to respond with, "It sounds as if you're worried," or "I know this is frightening to you." This way, you are acknowledging their feelings and supporting them. Now, this is a really good tip. Use this distraction. Call out their name. Look them in the eyes. Get their attention. Suggest that the person come with you for a walk or sit next to you in another room. Frightening hallucinations and delusions often subside in well-lit areas. You might also try to turn their attention to a favorite activity, such as listening to music, drawing, looking at photo albums, whatever it is. Keep these activities handy when you need them. Now, for some, it's really important to respond honestly. Keep in mind that the person may sometime ask you about the hallucination or delusion. They may ask, or they might say to you, "Do you see him?" You may want to answer with, "I know that you see something, but I don't see it." This way, you're not denying what the person sees or hears, but you avoid getting involved in an argument. That's what you're trying to do. This response also helps to normalize the person's experience. Use this tip only if the person asks your opinion. Now, the other thing is to acknowledge their distress and how they must be feeling. Dismissing their concerns or trying to distract them without acknowledging their concerns first can cause the situation to escalate and cause them to lose trust in you. For example, if the person thinks you are stealing, listen to them, acknowledge how they must be feeling, and suggest supporting them in finding the missing object. Just a gentle suggestion it's really very important not to become defensive at that point. Now, the other thing is modify the environment. As I said before, light makes a big difference. So turn on the lights to reduce shadows that could look frightening. If the person insists that he or she sees a strange person in the mirror when they're passing it, it's possible that the person doesn't recognize his or her own reflection. So why not remove the mirror? If the person has delusions about people stealing from him or her, have some duplicates of objects that you can sort of say, well, here it is. So let's look at how can a care partner deal with accusations. The person may may have accusations against people around them, including their family, friends, and you. The most common accusations is that others are trying to steal from them or harm them. They may also accuse their spouse of being unfaithful or of being an imposter. Being falsely accused can obviously be distressing. This is not easy to do. You need a lot of patience. Remember that it's the disease that is causing the behavior, not the person. So once again, please don't take it personally, and please don't argue with them. Try to find the reason behind the accusation and reassure them. Now, prevention is key. What is very important to keep in mind is that you are not alone in this. Many care partners are going through the same difficult situation. There are a lot of resources in the community to support you and help you cope. Caregiving in general can be very rewarding but stressful. However, if the person displays behavior of hallucination, delusion, or paranoid behavior, it's overwhelming. It's important to let family members and close friends know what you are going through. If the behavior is not managed by distraction or redirection or medication, and their behavior escalates both verbally and physically, you need to put a plan in place. What I mean by that is to ask family members or trusted friends if they would be available to come over once you call them that you are having a difficult time. Worst case scenario, call 911. You need to protect yourself as well as the person you are caring for. So the first thing, if things are happening, make an appointment with their doctor. If the behavior happens quickly, try to identify the triggers. It's really important to figure out what's going on. One of the best ways to do that is to keep a dementia journal. This may help you discover certain patterns or triggers. For example, certain behaviors may happen at certain times of the day, occur before or after meals, so it's important for you to know that. Be related to a physical or emotional need. They may need to go to the bathroom. Maybe something is hurting them. They're scared. They're anxious. What can happen with, even a change in routine sometimes causes that hallucination to escalate. So once again, when non-drug interventions are often effective, we know that medications can be helpful in some cases. When the person is persistently upset by the symptoms and non-drug approaches have already been tried, you might also want to ask the doctor to evaluate the person to determine if the medication needs to be added or adjusted or reduced the hallucination or delusion. If the person has a history of serious mental illness, such as schizophrenia, the hallucination or delusion may be related to that disease. It's important to work closely with the person's doctor to help determine an appropriate course of action. Hi, Joanne. We're just dealing with a few technical difficulties. I hope you'll all be patient.
You double clicked mute. Just click one more time. You were good, but you were muted. Okay.
Okay,
Yes.
you can hear me now? Yes, okay. Thank you, everybody. Thank you, Lucy. Those tips and strategies, they're always very reassuring, and thank you for all that content. I have to say to everybody, thank you for your patience. As Claire said in the beginning, this is our first attempt at a hybrid, and the technology is proving to be a little challenging. But here we are. So I'm going to jump on what you said, Lucy, and I'm going to offer one more medical condition. Nope, it's the previous slide here on delirium. Now, interestingly, we were not going to talk about delirium today, but so many of you, when you registered, sent us in the question about delirium. So we are going to touch on it. So delirium is a medical condition that's often confused with dementia and depression because it has so many similar symptoms. A delirium can present with confusion, hallucinations, delusions, and paranoia, just like we explained about dementia. And also apathy, sleepiness, anxiousness, restlessness, agitation, and anger, just to mention a few other symptoms. An episode of delirium can be caused by medical conditions like pain, infection, also poor nutrition, dehydration, medications, and very much a change in environment, such as being hospitalized. So why is it so important to talk about it? The difference is that delirium is sudden. That's how we tell it apart from dementia. Delirium comes on very suddenly. That's why I have a little red flag in the slide. It can be over 1 or 2 days versus over months and years with the behaviors associated with dementia. But even saying that, it can be hard to tell even for healthcare professionals. When a person with dementia also gets a delirium, they will have symptoms from both conditions at once, and that makes it even more complex. Go to the next slide. So who is at risk for a delirium? I want to start by saying we are all at risk. Every single person here. You do not have to have a dementia. Risk factors are 65 years and older, so that's including myself. Those who are more frail, those who already have cognitive issues or a diagnosis of dementia. If you are hospitalized, that's a huge risk factor. Having had a surgery, a broken hip, with serious or worsening illness, significant alcohol or substance abuse, if you have poor hearing or vision, if you're taking multiple medications such as antipsychotics, benzodiazepines, and antidepressants, and of course, if you've already experienced an episode of delirium in the past, you are at additional high risk. Oops, previous slide. Oops, other way. Backwards. Hold on. Yes. Okay. So why is diagnosis so important here? The treatment and prevention for the behaviors of delirium and dementia are similar, just as Lucy described. The non-pharmacological strategies and approaches are pretty much the same. You want to observe, you want to ensure that there's a very strong routine, especially if you've taken your person to the hospital. You want to keep routine. You can have a clock on the wall. You can have a whiteboard with what's going on during the day. Medical attention, pay attention to the medical symptoms and make sure the environment is calm and stable in terms of light and noise. But why is diagnosis so important in delirium? It's because if your symptoms of delusions, paranoia, hallucinations are from a delirium, this is reversible, unlike dementia. And that's why it's so important to get that diagnosis. So we'll go to the next slide. So I want to talk about something that I call the tipping point. So we've just talked about delirium. And if you've come to that point where you've already ruled out a delirium or a medical situation as an explanation for the behaviors, And let's say the behaviors are becoming more and more frequent. They're getting more difficult. And all these strategies and tips that were discussed in the first half of this webinar, they're just not working. They're not working well enough. They just don't work anymore. And you're the care partner. You may be coming to this point where you're questioning, and we call this the tipping point. Is this the right place? Is there somewhere maybe that is safer and better to be able to treat these symptoms more safely? And you may have already tried to increase your care at home care services, increase respite, take some time away, time apart. Then you may be looking at options such as relocation to care facilities. And if this is you, you are not alone. Even for trained healthcare providers, these behaviors are challenging even for them. We have the next slide. Thank you. So, because of the heaviness of the topic, I want to turn our conversation to hope. We all need hope, especially when we're going through the disease of dementia, whether we have it or we're experiencing it alongside as a care partner. We need to keep hope alive. How do we do this with this illness, with these challenging behaviors? So I want to offer you something, and in our next slide here, I want to offer you, besides all our tips and strategies, one word, and that word is curiosity. Curiosity. Curiosity can help give us hope. Staying curious. And to illustrate this, I want to share an example of something that happened to me just a few weeks ago that's given me hope, more hope. And I'm hoping that you can share that as well. So next slide. Oops. So here you can see a beautiful slide of our Douglas campus. And this is for those of you who came in person. Thank you to you. Most of you, the majority of you are online, but we are located here where the webinar is being hosted in such a beautiful big campus. It's the Douglas Mental Health University Institute. And I just want to mention that it is surrounded by beautiful green foliage, actually, which has the autumn colors now on this beautiful, beautiful day. Just come with me to this vision right now for a minute. There's beautiful walking paths and old buildings. And for those of you who don't know, the Douglas Mental Health University Institute treats persons with neurocognitive behaviors like dementias and psychiatric disorders that cause these challenging programs. So it happens that I have the privilege of supervising two Bachelor of Social Work students in their third year who are doing their internship with us here in the McGill Dementia Education Program. Ashley and Juliet, they're here today. And it just happens that a few weeks ago, we went to visit the Mo Levin Center. So the Mo Levin Center, part of this institute, is a 12-bed unit where patients with dementias and psychiatric disorders are referred from other hospitals and other long-term care centers with severe behaviors, as we've described today, the hallucinations, paranoia, all kinds of, imagine the most challenged behaviors are referred to this 12-bed unit. And they come here, they are referred here to get better and to improve. And this is where hope lies. And this is what I want to share with you. So we visited the unit and we met several patients with varying behaviors. And I want to share about one man that left a very big impression on myself and my student. And we walked through, and this man was yelling and screaming on the top of his lungs with everything he had. And as we approached him, he stopped. We were with the director who was giving us the walkthrough. He stopped. He smiled at us. He greeted us. He talked with the director. He even chuckled. And then we went along our way again, and he resumed screaming again on the top of his lungs. Did anyone try to stop him? No. Did anyone try to restrict him? No. He went on about his business, and so did we. We continued our tour, and so did all the staff and all the patients. Was he annoying, and was he really loud, and was it disturbing? Yes, but he was not unhappy, and he was simply allowed to be. Next, we continued, we went on the rounds, and this is where the multidisciplinary team gets together. There were 7 professionals there, doctors, nurses, social workers. They get together to review every patient in their team meeting. And they proceeded slowly in such detail, looking at every aspect, physical and emotional, the person's appearance, their skin, their eyesight, their hearing, what they were eating, what they were drinking, their elimination, their response to stimulus. I could go on, but they just looked at every aspect of that person. And my student is shaking her head. And all they were doing, which dawned on me, they were being curious. They were looking and observing and sharing and discussing and searching for things that they could try and do. And then they did it all over again with the next patient. What an example of how important it is to be curious. I have to tell you, I've seen a lot of rounds in my life, in my career. This experience stands out for me. For the patients whom this is their last hope, these 7 professionals diligently pore over the facts to figure out what they're going to try this week. And then they're back here next week and next week to do it all over again until there's progress, until they find the right cocktail, not just of medications, but of all the approaches that we've described today. I have to tell you, just talking about it, it brings the experience back. This is hope. I was not expecting to find hope here at the Mo Levin Center, but this is why I think it's such an important message to share with you all today. We must stay curious. We must remember that when someone presents with dementia, it's just too easy to explain away their difficult symptoms and behaviors and say, oh, it's their dementia. Can we have the next slide, please? So that brings up this difficult, though, and challenging point. We know it's so important to get a diagnosis. The diagnosis gives us the explanation. Why has all this been happening? And then we can, it might not be the diagnosis we want, but then we can move forward. We can get our education. We can acquire the knowledge that we need to be curious and to design some kind of a course of action for us. Even if there's no cure, we can still look at how can we prevent further? How can we delay? How can we manage symptoms? Then on the other side, if we're going to be honest, getting that diagnosis and labeling dementia brings a lot with it. It brings assumptions. In some people, it might bring indifference and ignorance, not a desire to educate, because you can say to yourself, but there's no cure. What difference is it going to make? And that can lead to resignation. And this is not what we want. And you see at the bottom of the slide, it says choose curiosity. But I don't have to say choose curiosity for everybody who's here today with us, because you showed up today and chose curiosity. And now I want you to take a look at the next slide. Oops. It's very delicate. It's very delicate, the slide changer. So if we take a look at all the faces on this slide, and I want you to imagine that these pictures of our older adults, imagine with dementia, with challenging behaviors. I just want you to take a second and look at their faces and just take a second to think what comes to your mind when you look at these pictures. What comes to your mind? And now I want to show you another slide. Now take a look at this slide. And I want to ask you the same thing. What comes to mind when you look at this slide? In the previous slide, I just want to go back. Yes, in the previous slide, I want to ask you a question. Have you ever taken your person to a doctor's appointment or to an emergency ward or just to a social situation? And they have their behaviors. And the first question is, of course, is there a diagnosis? And then you hold your breath and you say dementia. And then you hold your breath for the response. And the response sometimes is, oh, dementia. And then they may dismiss you, they may dismiss them, and all your hopes and needs along with it. Oops. I apologize for that. But now back to this picture. And I asked you the same. What do you see when you look at these little babies and these little puppies? I know I can share what I see. I see delight. Full disclosure, on the left are my two little grandbabies. I see delight, I see empathy, I see warmth, and I see love. And I see the same thing in the little puppy faces on the right. Now, when our little babies are crying and they're not well, something's wrong, and they're agitated, and they're behaving badly and screaming, do we say, oh, because they can't tell us, right? They can't explain. We're not speaking the same language. Do we say, oh, it's babies, it's baby behavior? No. We seek to understand, and we seek to comfort, and we seek to figure out what is wrong with our little babies. And if we can't figure it out, we take them to an emergency ward. And the same today. Look at our puppies and our pets and how people treat them. If our dogs are whimpering and uncomfortable and distressed, do we say, oh, they can't tell, it's doggy behavior? Not necessarily. We seek to comfort them and to find out what's wrong, and often take them to a veterinarian, and spend a lot of money on making them more comfortable. We need to be doing the same thing for these people. So we need to ask ourselves, when we present with our older adults with dementia, what do we see? What do they see? What do you see? And I just want to end by saying, let's stay curious. Let's use curiosity, and let's have hope. Thank you. That concludes the presentation part of the webinar. We're going to stop sharing the slides. And now Lucy and I are both going to come back together with you. There we go. So hello, everybody. Hi back, Lucy. Nice to see you.
Thank you. Thank you.
So we hope you appreciated the information content of the part of the webinar. And now I want to invite anybody who has questions for us. Do you want to put them in the chat? Do you want to be brave? It's not required. Or anybody in the room here with us. Lucy and I are here with you for at least the next 20 minutes, and even maybe a little bit more if we need it, to answer any questions you may have.
Can I?
Yes. Do you want, I'm wondering if our audience can hear you, but make your comment and I'll repeat it. So first, thank you. Thank you for being present with us.
Yes. I'm Doreen Ashton, and I was the first director of the Moldovin Center.
Hold on. Can everybody hear?
Not too well.
Not well? Are you able to come a little closer, or?
Just repeat. Maybe
Yeah.
I can repeat what you said.
Okay, so we have Dolly Dastour speaking with us. So if you could just speak loudly, so maybe our participants can hear us, can hear you.
I'm Dolly Dastor, and I've been in Douglas Hospital for 40 years, and I'm retired now. But I was the first person to set up the Moldovin Center. It was set up on the principle that we treat the whole person. And it was specially designed to make it a very home-like atmosphere so that the elderly person does not have a cold, sterile atmosphere of the hospital. It's like a home. If you visited it, if you see, I don't know how
Yes.
much they've changed now, but it was
Yes.
completely old-fashioned things like that, the clock on the walls, the music, the beds, everything. It was considered to be the star in Verdun because people came here and didn't want to go back home. They didn't want to take them back home, you know. So that's what I'm saying. The people especially trained in how to manage people with dementia and how to deal with them. The doctors and nurses and everybody was trained in that particular profession. And so that is why I think it was very satisfying because we treated as it was on a continuum of care. If the person came in from the day center, if they were worse off, then progressed to the inpatient unit, you know. And then there's a memory clinic. So that the whole patient and the whole gamut of the disease was treated there, from the most severe, the least severe to the most severe. So that was the whole concept of it on the continuum of care.
Thank you for sharing.
Thank you so much.
Were you able to hear that?
Yes, we were able to hear, and I want to thank Dolly. There's a lot of things in the chat. And Christine,
Okay.
there's a lot. And Christine has her hand up. If you
Okay,
can.
I just want to just summarize the important point that Dr. Dastoor made is the importance of education and training for care partners, but also for professionals. Thank you. Go ahead, please.
Okay,
How can we
I'll go for the first comment. Okay, for someone with dementia and delirium hallucinations, how would you recreate familiarity in a new house if they have to move homes?
Okay, Lucy, would you like to start?
I think that's an excellent question because environment plays such an important role. But I have to say that even when we always encourage, even if the person goes into long-term care and to a different setting, it's so important to bring us and to negotiate with the establishment to bring as much of their what's important to them to that home as well. It could be furniture, it could be pictures, obviously, but it could be other very things that are very meaningful. So I think that's being curious too. Joanne, I really love that whole concept of being curious, of knowing what the person you're caring for, what means a lot to them, and to be able to actually bring those items with, for sure.
Add to that, to what Lucy is saying, when we designed the thing, outside each door was a memory box. And we invited the families to bring in something, souvenirs, which they could relate to. And that was a two-way thing. So we, the staff, could also know what sort of life that person has led. Some people have done some fantastic work with the governments, some with sports, whatever. So that was the focus, both two ways. We would understand what they were, and they would try to imagine what they were before.
Thank you.
Thank you both. Yeah.
The memory box was very important.
So we have a lot of questions. So thank you, Lucy. I'm not going to add to that. Let's try and take some more questions.
Okay, why
Maria?
don't we, since Christine has her hand raised, we'll ask her questions.
Okay.
If I can manage to unmute her. I think she has to unmute herself. Are you able
Christine?
to? Yeah.
Thank you. That worked out perfectly. So
Great. Hi,
first, I
Christine.
want to say thank you so much. I found this so helpful. I'm calling from Toronto. My father-in-law has vascular dementia. His delusions tend to be around him believing he is in a hotel and he is in Buffalo and needs to get home. And the problem seems to be that he gets very anxious trying to plan this trip to get home. And the anxiety, he spirals and spirals. It's very difficult for my mother-in-law to deal with. And the question I have is, going back to the slide with respects to dealing with these delusions, we have been participating alongside, saying we'll pick you up tomorrow at noon, we have American Cash, but it sounds like based on that slide, that's not the right approach. Can you please let me know what would be the right approach to dealing with Peter when he has these delusions and it's consistently the same one?
Mm-hmm. Do you want me
Go
to?
ahead, Lucy. I'll come in after.
Okay, that's a great question because a lot of people can relate to it in different ways, when it becomes persistent. Now, I guess my first question to you would be is how long, is this something new? Is this behavior new?
No, she said it's been repeated.
It's been for a long
I'm
time?
not sure, Christine, if you're still muted. I heard her say it's the same delusion over and over.
Okay,
Yes, I'm sorry, I'm unmuted. It is the same one over and over again, but I would like to add he just was sick with a kidney infection, and so I wonder if this sudden decline is also related to
yeah.
what you were just referring to the other
A
D word.
delirium.
Delirium, yes, but it has been going on for several weeks, and it is always the same one.
Okay, but that's a very important. Several weeks it's not that long a time. And the first thing that I would do is take him to see the doctor because there could be something going on physically with Peter.
Well,
That-
we have had a CT scan and it came back
and blood
normal,
work.
unremarkable.
Yeah. Again, look, you've tried different ways of dealing with it. I think that one of the things that you could do is try to distract him. I think whatever you're doing is good. You're trying to tell him you're going to take him tomorrow or whatever. But at one point, if it becomes really so upsetting to him, I think maybe you should speak to the doctor about some form of medication just to calm him down a little
Okay.
bit.
Excellent. That's very helpful. Thank you so much.
You're welcome.
I would also like to add, because you questioned in the beginning, are you doing the right thing? I just want to concur. You are carrying out the strategies we're describing by accompanying him in this. If it's distressing, you might want to also try in the accompaniment of the delusion, asking what is he excited about doing this? What is it that he wants to try to tap into some more positive emotions more than the agitating emotions to see if you can sort of use a combination of distraction but going along with this delusion. Just one
Okay,
more.
that's incredibly helpful. Thank you so much. Thank you so much.
You're
Pleasure.
welcome. There's someone else?
I have another, is there another hand raised? Oh, there's a couple, I'm gonna go
Audrey.
to the chat first and then we'll go to Audrey, okay? So we'll do you tell someone diagnosed with dementia that they have it? If you take someone to their doctor, how do you discuss behaviors in front of someone who doesn't believe there is an issue and they don't have dementia? Everyone else does, but not them.
So maybe Lucy, I'll start with that. I
Sure.
think if discussing the dementia and the behaviors in front of them adds to the distress, I would try not to do that at the actual moment. A good way to do it, it's something that I've done, is if you know you have a doctor's appointment coming up or a meeting, give information ahead of time to the person, or to the doctor or to the team, so you can describe accurately, send an email. I've even sometimes come in with a little written paper and I've given it to the secretary and I've said, could you please give this to the physician in advance? So it just helps by sharing some of these behaviors and not doing it in front of them. That being said, the answer really depends on the stage of the dementia, the level of insight, the level of comprehension. And the only person who can answer that is you, knowing your person, trying things, seeing how they react. We do try to be honest. We do try to share and see what's the reaction. And then it's simply trial and error. So that's, Lucy, I don't know if you have anything to add.
No, I think that you said it exactly as I would have.
Okay, I'm
Okay.
gonna quickly unmute Audrey and then so we can move along. There's a lot of comments. So here we go. Hey, Audrey, I'm trying to unmute you. There we go.
Hi.
Hi, Audrey.
I just wanted to say that I've been enjoying this session, both from the perspective of my previous husband having passed away from Alzheimer's, and now myself being diagnosed with early identified Alzheimer's, and taking drugs for that. That the advice is very, very positive and affirming, and it works.
Thank you
Especially
for sharing.
for the distractions of getting into their reality and then getting them out. I know on one occasion my husband jumped out of bed and walked outside in 40 below weather to fix the pool, and I had to go outside and say, darling, don't you remember we called the repairman, we need the motor, it's coming at 10 o'clock in the morning? And he said, oh yes, I forgot, which wasn't true at all, but he came in. So you have to sort of really dive into their reality and then find a means to bring them out. And I just found that was the most effective way of dealing things.
Thank you.
Thank you for sharing your experience.
Acknowledgement is very, very important. And that's part of not arguing, acknowledging people's feelings first and foremost. Thank you.
So we have another comment here. How to help someone that is in a crisis and says they would prefer to die or to be dead. Even some say, I'll just kill myself. How should we react?
As you would in any crisis, first always evaluate the dangerosity. And I don't mean just physically, I mean emotionally too. If the person is saying it and it's a repetitive behavior and you can change their mind, it's one thing. If they're in really deep despair, I would call a physician. I would try to get help, because when you're in pain, whether it's physical or emotional, it's impossible to function. So this would be, for me, somebody crying out in pain and saying, please help me. I can't bear it anymore. Lucy, this is where I would seek a medical consultation.
Exactly.
I wouldn't just leave it.
On a personal level, this is not easy for me to share, but my mother, when I was caring for her, there was a time when she just didn't want to live anymore and she wanted to die. And I had to take it very seriously and give her the opportunity to speak about it to her doctor.
I just want to add one thing on that. If it's not to that level of distress and you do want to use distraction, photo albums are a really good tool. I would have photo albums out on the coffee table for a host of things, because remember when we looked at the babies and the puppies, looking at that does something to your brain. So if you open photo albums and you can look at your family as children or the past, sometimes it can trigger something that can distract them as well, as long as we're not talking about really that level of dangerosity, physically and emotionally.
Okay, so we have another one. If you could kindly comment on how to react when the accusations get to the point of being aggressive insults and dirty language.
I'll let you answer that one, Lucy.
That's really a difficult one. And we keep saying, don't take it personally first and foremost. Just recognize where it's coming from. It's hard to say because I don't know what stage the person is at. And, they might be in their later stage of their behavior. Again, not to take it personally, not to react to it. It's not easy, but you have to remember where it's coming from. Again, I have to say that all these tips that we were talking about, distracting them, redirecting them, if all else fails, and remember at the end, I said that you have to put a plan in place, okay? What I mean by that is very much that you need to share with trusted friends and family what you're going through and to make sure to see if they would come over. But you really have to make sure that, especially if it becomes physical, I can tell you one thing, and caregivers always tell me, well, he only hit me once. If he hit you once, it's going to happen again. So having a plan in place is important. And as I said, even having to call 911 last resort. But that person needs to go back to the doctor, needs to maybe again, we don't, we prefer non-medical interventions, but you have to keep yourself safe and you have to keep them safe. So maybe it's time to think of relocation. There's many other ways of looking at it, but don't let it go. If the person is really becoming more aggressive, physically and verbally, you have to do something about it.
Okay, I'm going
Next
to,
question.
the next question is about whether it would be recording, and we are recording this and it will be shared. It might take a while to get onto the website. Somebody commented about asking the comments to be summarized. I think we'll just move along to the next question, which is more information, a request. Our family is 13 hours away from my sister who has Lewy body dementia. Partner is the caregiver. Sis calls me when she has delusions that a bunch of imposters of her partner are there, not her partner. She is crying. Suggestions for how to comfort her on the phone.
Music,
On the phone?
distraction. You know what? You're presenting a very challenging situation. It's hard enough to do this in person. How do you do it on the phone? I would start with how do you reach this person? What connects to them? What comes to them? They're calling you in distress. These are distressing delusions. Go for it, Lucy, if you want to add anything.
I think first, especially on the phone, must be very, so take a deep breath. At least the person is calling you. So the first thing you want to do is to reassure them. Tell them, okay, I'm so sorry that you're going through this. How are you feeling about it? Acknowledge it, okay? But don't get into too many details, and not to exaggerate whatever it is that they're hallucinating. And as Joanne said, at that point, distract them. Talk about yourself. Say, oh, and by the way, I want to tell you what happened this week. Or if there's other family members around. Or as Joanne said, it's okay to say, I just heard something amazing, this amazing music, or put it on, or start to talk about the past, about what happened in the past, and try to get that person. But the point that I'm trying to also make, it's not going to go away. You're going to have to use this kind of a tip over and over again. And it is very upsetting. And maybe sharing it with the person that is the care partner and letting that person know how often they're calling and has something changed, what's going on. It could be maybe they're tired, they're hungry, all the things that we were talking about, and encourage them to maybe, if they haven't had a physical in a long time, maybe it's time to see the doctor once more. But it's something that what Joanne was saying, the curiosity part of it is always there to see, like, how can you engage them and find different ways of soothing that person.
You know what? I'm just going to add, because somebody added on the in the chat that I see that they're also experiencing what our current speaker is telling us, and they use FaceTime. So if you are able to transfer the call to FaceTime, and I was not joking about using music. When Lucy describes being soothing, putting soothing music on, we talk about the environment, the atmosphere. It really is challenging on a phone. But here's where we have to really be curious and think out of the box.
I was also at singing. I have to tell you.
Singing.
It's really something.
Yeah.
It could be funny, it could be soothing, even if you don't have a great voice. But it's a distraction.
So we have a lot. Sorry.
I know it's noon. Are we, Lucy and I are okay to stay a little bit longer? Are we okay to stay another 10 minutes? Is that okay?
Sure.
For those who have to leave, I don't know, Maria, if you need to make an announcement and we can continue for another 10 minutes, and we respectfully, those of you who need to leave, Thank you for coming, but Maria, do you need to announce?
No, that's okay. There's nothing to announce. I can just keep going on with the comments if you would like.
Okay.
So the next one is another question. My mother, dementia since 2018, just went through a major emergency surgery, small intestine. During her recovery, she's been having a lot of hallucinations. How do we figure out how much is due to the fact she is not at home and in the hospital, and how much is due to her dementia?
My first question would be to step back a little bit and ask, why is this important to me? How is it going to help me? So that you can ask yourself that, because the fact is that she is experiencing these. If your person is still in the hospital, I would bring up the situation and ask, is this now due to the delirium? And if the physicians and your medical team can help with the diagnosis, that might give you some sense. I don't know if you remember in the presentation, I mentioned if somebody has dementia and a delirium at the same time, it's extremely complex. And it is, we have Dr. Dastoor here who's shaking her head. It might be near impossible to figure out what's contributing. So the key thing is to focus more on the approaches, the treatment. If they are due to the delirium, some of them will subside over time. When I say it's reversible, it doesn't mean because a delirium comes on in 1 to 2 days, it doesn't mean a delirium leaves in 1 to 2 days. It will take some time. And I'm sorry you're going through this, because this is so challenging, the mix of the two. And I see Lucy shaking her head. We really do feel for you. So I would just step back and look at, what do you really need? Do you really need to know the difference, or do you need more to talk to the medical team or your team about, how can I make this better? How can I make it as good as I can?
I just want to say that it's really important. When you see someone having hallucination and delusion, it's upsetting. But you have to see, is it upsetting the person?
Yeah.
If it's not upsetting the person, then let it go. And it's okay, as Joanne started to say, what is the difference? The difference is only when they are really frightened about the hallucination delusion. That's where the concern should come in more.
Yeah, and also the patient.
Sorry, Dr. Dastoor had something to add?
I'm saying also, if the person is not any danger to himself,
Yes,
or herself, and to the others, just leave it. Just let them be. Go away. Not go away,
Yes.
but
were you able to hear that?
Yes.
About dangerosity. If there's no danger to them and no danger to you, leave it. I mean, it's distressing. We want to acknowledge that. Yeah. Thank you. Thank you for the question.
Okay, here's one. You mentioned that diagnosis is very important. However, the gerontologist at the JGH gerontology unit was not willing to have my spouse seen by a neurologist, have a repeat MRI, or have any further diagnostic tests. Is the specific cause of dementia and severe memory loss important to determine?
Do you want, I'm going to say a comment first, and it's hard because we don't.
What's the question again?
The question is it, sorry, Dr. Dastoor, is it relevant? Which kind of dementia? How relevant is it to have a diagnosis that really specifies the type of dementia?
Yeah, I think it is necessary, because different types of dementias will have different approaches to it.
Where's Dr. Dastoor?
If you have a frontotemporal dementia, that will be a different type of an approach to. You have a Lewy body disease, that will be a different approach to a different type of treatment, different non-pharmaceutical approaches as well. And if you have an Alzheimer's disease, then you know what stages you're going to go through. In the other dementias, there may not be real different stages to go through. So it's just important to have a proper diagnosis.
So there you hear it from Dr. Dastoor. And, sometimes this can be really tricky to go back to your physician. But I think we have to be curious, and there may be more involved. There may be more information, maybe that I would be curious and ask him, what is the reason why he or she is hesitant to share this information? And you can share that you were watching a webinar or educating yourself, and this is your understanding. And I want to take the opportunity to say in our relationships with the professionals, our physicians, the team is so incredibly important. We have to develop trust. And it's okay to speak up. And don't forget, people in the system, including myself, we're so rushed, we're so busy. Sometimes we're on the fly. Sometimes they just might not have had enough time to give you a proper answer.
I would also mention that if you're only dealing with your family physicians, they normally tend to dismiss everything memory problems as dementia.
This was at the Jewish General she's mentioning.
Especially.
Yeah. And if this was a spell, so Dr. Dastour's adding that if it's your GP, you might need somebody more specialized. But I would go back to that one word we offered, which is curiosity, and add another, which is advocacy. And, you have the right to speak up. What's the worst thing that can happen? But if you speak up and ask for what you need, you may get it. And good luck to you with that.
Okay, here's the next question. This one's about a hallucination. How do you deal with someone that is convinced they have a deep and significant relationship with a person that is not really present in their lives? This creates a lot of sadness and anxiety as she cannot contact this person or doesn't see them when they think they have something planned.
Well, that is very distressing. Must be very distressing to the person, must be very distressing to you to see the person you're caring for in such a situation. And I have to say, we have to go back to the tips that we were talking about. It takes a lot of patience, I have to tell you. It's almost part of a routine, like you would, you get up in the morning, you brush your teeth. When this happens, this is the routine. The routine is to try to distract them. One of the things that's extremely helpful is if you hold the person's hand and call their name, look into their eyes. What you're trying to do at that moment is to get their attention. And what you want to do with someone like that is you don't necessarily want to acknowledge it at that particular moment. You want to distract them. So when we were talking about having activities handy, one of the good ways to say, come on, I really feel like having a cup of tea. Let's go somewhere to the kitchen and have a cup of tea together. Whatever it is at that particular time, go and open up the TV, music, any activity. It's difficult, but it's a routine and that's why we say to keep a journal. Try and figure out, when is this happening? Is it after a meal, before a meal? Do you think maybe this person needs to go to the bathroom? These are all the things. That's the curiosity thing about trying to manage it. Patience and time. You need time for all of this. But this is the only thing that I could say that in many times it does work. So I hope you try it, and thank you for telling us, and wish you all the very best.
Here's another question. Can a rigid, long-lasting delusion without apparent memory loss or diagnosed dementia exist and persist as an isolated symptom, or is it usually associated with the eventual development of dementia? I don't know.
You're asking
a question you can answer or not.
I have to be honest with you. I'm not a neurologist, and I know Lucy's not a neurologist. These are really interesting questions. I am for sure not equipped, Doctor.
What did she say?
But I think these are really more of a medical nature. I don't know if you want to so go ahead, Lucy.
No, I mean, the way I heard it was more that this person does not have dementia, but maybe it has to do something with their childhood and experience that they had. We're not here, I'm not a psychologist either, but I think that it's maybe important to be able to have a proper diagnosis of what's going on there.
I think we can guess because it could be due to a psychiatric illness,
Exactly.
which has nothing to do with dementia. And psychiatric illnesses also, and other physical illnesses can cause these things. Again, thank you for your question, though.
Um,
And
Hello, I have limited knowledge about dementia, and I would like to ask if the symptoms are the same globally. For example, do seniors experiencing dementia in Asia, Canada, or Africa exhibit the same symptoms? I am particularly interested in this question for an immigrant senior and how they can cope with the experience. Additionally, are there hereditary factors related to dementia?
That's such a fascinating question.
well,
I'm going to turn you, sorry, Lucy, what did you want? Then I was going to turn you
Well,
to Dr. Pastor.
Yeah, I was just going to say we at one point in my career, a lot of Japanese geriatric doctors came here to talk about very much the same way. So all I can say to you, I think across the world, I think it does, dementia affects people probably the same way, but culture comes to play a lot.
Yes.
It's how we respond to that. For example, I had a PhD student from the Middle East who basically said that in their country, there is no dementia. Okay? Because they accepted the fact that as you age, you know, you might become forgetful, but we're still listening to what they have to say. So I'm just saying it in a general way from my own experience, having worked with different communities.
Oh, I love that share, Lucy. Thank you. Just a minute. I'm sorry, Dr. Dastoor, a comment on differences across the globe.
I have lived in West Africa and in India and here. And I do see the differences in the contents of the hallucinations.
The contents.
Yeah. Those are different, you know. But in West Africa, my experience was more with schizophrenia. And the contents of the hallucinations in schizophrenics was very much different in West Africa than I would see it over here.
Also interesting.
Very cultural, very religious, very mythical sort of illusions, you know. And then, and also as Lucy mentioned, that in West Africa, when people get older, they're accepted and they live in the villages. And so it was accepted that, okay, you forget it, that's fine. You know, you're incontinent, we'll change you. That's okay, you go. So it's more acceptable than what over here. We're living in one room, 2-bedroom apartment. It's very difficult.
Right. So that's very interesting. The whole concept of acceptance and the context.
I just want to say one thing to the person who asked the question. If, you know, it's very important culturally, if the person has to be placed in a long-term facility, to try and find a place that is culturally sensitive to them.
Okay,
Maybe we'll take one more question, Maria, or the last two. It's
okay. Well, there's a lot of thank yous. Excellent session. Someone asking, can we do one maybe on the medication that can assist? That's maybe something that we've discussed on McGill Cares before. Somebody said these questions are so helpful. I would love a follow-up that is purely Q&A about specific examples. Hearing your suggestions about specific examples is great. Learning by your modeling. Somebody saying, yes, distraction is a great strategy. Thank you for the presentation. Memory box or book can be used this way. Another thank you. Someone mentioning sunshine always helps with their mother, bringing them outside in the sun. Somebody saying you skipped my question about the diagnosis. I think we did answer that question about.
Could you repeat the question?
So, sorry, this question is you skip my question about the diagnosis. Was this deliberate or is it too difficult to discuss? But I think that was the question about, you mentioned that diagnosis is very important. However, the gerontologist at the JGA.
Okay, so we covered that.
I think we did discuss that. Yes.
I think there's something from David. I see one.
Is that near the bottom?
I don't know. It just popped.
My wife frequently comments that she's going home when we are home. I think this relates to her childhood where she lived in a different region.
Yeah, and you know, the same message that we give, if it's not distressing, go along with it. I do want to share my late mother-in-law suffered from dementia and had a major delusion about a third son coming and an inspector coming. And when I would go and visit her with my husband would join her in this delusion to the point where we would name the inspector Inspector Clouseau and bring humor into it. And just the use of humor and going into this whole delusion altogether. And we would say, tell us more, tell us more. So it's really finding that angle in using everything that you can think of that works with your person to try and bring what it is. Remember the man yelling in the hospital? Just bring what you can to reach that person and then allow them to just be.
May I add something to that?
Please.
To end
Dr. Destour's adding
that the
a tidbit.
success of any relationship between the client and yourself or the family members would depend on your pre-relationship before the dementia started. If you've always had a very happy, successful marriage or relationship with the parent and child, then your caregiving will be much more different, very different than if you had a disharmonious, antagonistic relationship before. You will not tolerate as much as you would if you had a very happy relationship. So keep that in mind, and this happens occasionally.
That's a great topic for another webinar.
Thank you very
I think-
much. Thank you, Joanne and Lucy, and all of you who are participating from home or work, and those of you who came and joined us here at the McGill Research Center for Studies in Aging today. We will be posting the recording eventually on our website. We want to know what you think of Caring Conversations, so we will be sending a link to a very short evaluation by email. Please fill it out as soon as possible so that we can see what works and does not work and see if you have any topics suggestions. Next month, we'll be returning to the online only format. We will be looking at home care and care home options. Lucy and Joanne will talk about recognizing if it is time to transition to a supervised care home and coping with the feelings that accompany making that type of decision. Once again, Caring Conversations is a project of the McGill Dementia Education Program, which is funded entirely by private donations. If you would like to join our mailing list to be notified about important programs and resources, please email us at dementia@mcgill.ca. Thank you very much.
Thanks,
Thank you,
everybody.
everybody.
Take
Bye-bye.
care of yourselves. Bye.